So CAR T cells certainly have had a great start in treatment of relapsed refractory multiple myeloma. We're really seeing some incredible response rates, but also deep and in some patients, very durable responses. And so whenever in the late stage therapy, we see such a dramatic effect, we always want to bring it into the earlier lines of therapy. So there's many places where I think this would be appropriate. First and foremost for early relapse or for patients that don't have a good response or an acceptable response or a better than PR to induction therapy. I think those patients could benefit from a CAR T cell therapy as part of trying to induce a deeper response to frontline therapy or trying to treat early relapse. We know that the T cells in those patients are likely going to be better functioning T cells. And we're hoping that those better functioning T cells, in fact, will translate into even deeper and better, a more prolonged response. I do think there are going to be some patients that are cured with CAR T cell therapy. In the current space, in the relapsed refractory myeloma, I have patients that are coming in for bone marrow, 3 years later and 4 years later and still in remission, MRD negative remission, and those patients may never relapse. But that would be great. But we need to but that number is small, and we need to try to increase that number. And I think by doing it in an earlier line of therapy, we can do that. I actually think it'll replace autologous transplant in the frontline setting. I think patients will get induction therapy, and then we'll get CAR T cell therapy as consolidation. And in terms of the biggest question, is it one and done after the CAR, or are we going to have to do some maintenance after the CAR T cell therapy? And I think that's where the novel investigations are going to proceed in the next 5 to 10 years to answer that question about maintenance.